So I'm Abner. We're going to continue on with ENT Ophthalmology Day. Now we're going to talk a little bit about ultrasound, ocular ultrasound. So we're going to review the anatomy of the eye. We're going to learn the indications of ocular ultrasound. We're going to learn how to do this type of ultrasound and get good quality images. And then we're going to be seeing a bunch of pictures and videos of positive findings that we can see in our ultrasound. Finally, we're going to be discussing the benefits and limitations of this kind of ultrasounds. So in terms of the eye shift complaint, initially, like I remember being an intern and looking like this whenever I had to see an eye complaint. And it's actually kind of easy. If you follow a systematic approach to the eye complaint, essentially you're going to be evaluating every patient very similarly. So let's start with our HPI, and we have been discussing this throughout the day, but you're always going to ask whether this is traumatic or atraumatic, if this is painful or painless, if this started suddenly or kind of have been progressing for the past few days or weeks. You gotta ask if this is bilateral or unilateral. You gotta know if there's any itchiness, any foreign body sensation. And then I think very importantly, if there's any flashing lights, floaters, if they feel like they're seeing a curtain in their eye. In terms of past medical history, most of the pathologies we're going to see, especially the traumatic ones, are going to be associated with diabetes and hypertension, which I don't know how that is super useful because everybody has that. But something to be aware of, especially in our population, sickle cell anemia that they are predisposed to some of the pathologies we're going to be seeing. Also cancer, you got to think about metastasis to the brain, that can increase the intracranial pressure, and that can have ocular findings. Otherwise, always ask about prior eye surgeries, prior eye procedures, and always ask whether they are using any medication like drops for their eyes. In terms of physical exam, like something important is that the ocular shift complaint is going to take time. Like try not to pick up the eye pain with vision loss, and at the same time pick up the laceration, because you know those two things are going to take a lot of time, and it's important to be thorough on your exam, because it's going to give you a lot of information. You're going to be able to know what's going on, especially from your physical exam. Another thing is that eye complaints, there's a lot of pathologies that are in terms of HPI, and depending, of course, on whether the patient is a good history or not, they are going to tell you very similar situations for different kinds of pathologies. So it's important to your physical exam. You're going to start with the inspection, right? And you can do it without any instruments, but if you want to be more thorough, you can use a slit lamp as well. You're gonna assess your extraocular movements, the pupillary reaction. You're gonna assess your visual fields. Always important to do visual acuity. Remember to use your corrective lenses if they use them. Plus or minus fluorescein stain, depending on your degree of concern for an aberration. Always do the IUP, and then finally focus on the reason the POCUS is actually going to be used to evaluate the posterior chamber of the eye. However, the gold standard, it's going to be fundoscopy. Now, we were discussing earlier that a lot of the fundoscopes in the emergency department are actually non-functional. Number two, we don't necessarily are the best in using fundoscopy. And we feel very comfortable using ultrasound. So that's one of the the pros of using ultrasound. Okay. All right, so now we know what to do. Indications of POCUS, ocular POCUS is going to be loss of vision or decreased vision. Anybody with eye pain, anybody who you suspect a foreign body, anybody with a hand injury, eye trauma. And then something important is that even though I say that fundoscopy is the gold standard to evaluate the posterior chamber of the eye, if somebody has a lot of edema, maybe a hyphema, maybe cataracts, they have intravitreal hemorrhage, then you're not going to be able to assess the retina using your fundoscope. So in that case, ultrasound can actually be better than your fundoscopy. Okay. So how to do it? First of all, it's important to explain the procedure. It's very scary when somebody is like doing stuff in your eyes and you're not seeing anything that's going on. So take your time and explain the procedure. The next part is optional. You can put the tegaderms in the eyes to avoid gel going into the eye. Having said that, the gel is not really harmful to the eye. It's water-based. So if it goes there, nothing happens. However, it can be uncomfortable. What I personally do, if I think this is like an older person that doesn't really understand what we're doing and maybe is a little bit afraid and they might open their eye, I usually put the tegaderm. If it's a young health patient who totally understands what we're doing and they can cooperate with my exam, then I might not necessarily put the tegaderm, and then I avoid seeing this pocket of airs in my ultrasound. Use a lot of gel, honestly. The more gel you use, the less pressure you need to apply to the eye, and it's going to be more comfortable to the patient. Next, you're going to use your linear probe to do this ultrasound. You guys know how we decide what kind of study we're doing, like if it's abdominal, cardiac, whatever. We can start by setting the ultrasound into ophthalmic or small parts. And that's going to help us with our gain and get better images. So we always are going to assess we're going to examine the eye in transverse and longitudinal planes. And then it's important that when you hold your probe, you got to put you got to stabilize your hand. So one way to do it is just to put your pinky in the nose of the patient when when examining the right eye, and then in the zygomatic bone when examining the left eye. Okay. So anatomy of the eye. Remember, anytime we're using an ultrasound, whatever is on top of the image is whatever is closer to the probe, right? So we're gonna see the eyelid first, then we're gonna see the anterior chamber. After that, we're gonna see the lenses with the iris, the vitreous body over here, and then the retina, and finally we're gonna see our optic nerve. Okay, so again, let's convolute image, pupil first. We're gonna see the lens over here, iris, vitreous chamber, retina, and then the optic nerve. So I'm gonna give you guys a few seconds to scan this. Essentially, it's a link to this PDF. I usually use this because there's a bunch of pathology that you can see in your ocular exam, and when you see a positive finding, you might not remember just because there's a bunch of stuff that you can see. So if you don't remember exactly whatever you're seeing means, then you can refer to this PDF, which is just one page. And then I'm gonna be you're always gonna through the presentation. You're always gonna see one of these images on the bottom right corner of the slides, just so that you kind of correlate those images to the actual images in the ultrasound. Okay. All right, so we're gonna start with painless vision loss. We have a 60-year-old patient who presents today for loss of vision in the left eye since yesterday morning and became progressively worse. The patient says that he had a sensation of a curtain coming over his affected eye, and now it's affecting the central vision. He said 7 days ago, he noticed like flashing lights and then some floaters. He didn't notice any pain, no diplopia, no halos, no other symptoms. He had a cataract surgery 3 weeks ago. And then on physical exam, the most important thing is that the visual acuity is decreased on the left eye. All right, you do a POCUS. What are we seeing over here? Just by raising hands. A, retinal hemorrhage. B, vitreous hemorrhage. C, retinal detachment. D, vitreous detachment. E, retrobulbar hematoma. Okay, so I saw most people raise for retinal detachment and some people vitreous detachment, which is okay because they look very similar on ultrasound. Okay. So the reason I decided to do retinal detachment first is because if ocular ultrasound is good for one pathology, it's going to be for this one. Okay. First of all, retinal detachment is an emergency. It's a do not misdiagnosis. Ocular ultrasound is 97% to 100% sensitive and 83 to 100% specific for retinal detachment. And that is when it's done by emergency medicine physicians, not even by ophthalmologists. So we are good at detecting this, and the ultrasound is a good tool. It's going to present as new onset of flashers, floaters, maybe a dark veil or curtain, decreased peripheral vision or central vision loss. And in ultrasound, you're going to see this hyperechoic membrane in the posterior chamber that is mobile. Something important is that it's going to be attached to your optic nerve. And that is important to be aware of, because that's the main distinction in between retinal detachment and vitreous detachment. Okay. So vitreous detachment is also going to present with floaters in the eye, usually sudden. Based on physical exam and HPI, it's going to be very difficult to distinguish between retinal detachment. But it's important to evaluate either by ultrasound or eventually by fundoscopy, because retinal detachment is an emergency, but vitreous detachment is not really an emergency. That can be managed outpatient. The ultrasound is not very good in terms of sensitivity for this. It's only 40%, but it's pretty specific. It's 96% specific. Having said that, if you don't see anything in your ultrasound and somebody's presenting with floaters, you probably need to do a fundoscopy and call ophthalmology, not necessarily for being concerned about vitreous detachment, but more about retinal detachment. Okay. So again, in retinal detachment, the sheet, the membrane itself is going to be attached to the ocular nerve, whereas in vitreous detachment, it's going to cross the nerve. That's the main distinction. All right, so let's practice. What are we seeing over here? Excellent. Yeah, totally. That's a vitreous detachment right here. But if you look really closely, there's a retinal detachment right here. Okay. So my point is they can both happen at the same time. All right. So if you diagnose vitreous detachment, cool, excellent. That's not an emergency. Always look for the retinal detachment. Okay. All right. This is from 5-minute EM, which everybody uses for this kind of lectures. I don't know how to do a lecture without 5 minutes on. Okay, so next one is retinal hemorrhage. Retinal hemorrhage is usually not an emergency. It's managed outpatient. It can happen. It can be traumatic or atraumatic, and it's also going to present with very similar symptoms. So sudden vision loss, maybe blind spot, patches in their vision, floaters, flashes, and what you're going to see, it's similar to retinal detachment, right? You're going to see this membrane over here, but you're also going to see this hyperechoic or gray fluid behind the retina, which is different from retinal detachments, where you see hypoechoic fluid below. Okay. Vitreous hemorrhage also present very similarly in terms of the shift complaint and HPI. It's associated with diabetes, usually a traumatic, but in the setting of, especially in babies, the classic is shaken baby syndrome. It can be, traumatic. It's also associated with sickle cell anemia. And what you're going to see is what is called the washing machine sign. And essentially, you're going to see a bunch of debris in the vitreous humor. Okay. So, ultrasound is pretty sensitive for this. It's 81% sensitive and 82% specific. Not as good as fundoscopy, but pretty good. I think the main thing about this is that if somebody has this pathology, vitreous hemorrhage, it's going to be very difficult to assess for retinal detachment because with fundoscopy, I'm saying, because all that blood is going to be covering the retina. So in this case, ultrasound can be better than fundoscopy for evaluation of retinal detachment. Okay, 65-year-old male with history of smoking, hypertension, hyperlipidemia, presenting to the AD because he's unable to see from the right eye for the past 10 hours. Symptoms happen suddenly, denies any pain or eye trauma. 1 week ago, he was having dinner. His right eye became blurred, then completely black, and returned back to baseline in like 1 to 2 minutes. Later on, he was reading the newspaper, and something similar happened. Ocular and neural exams are within normal limits, except for inability to see anything from the right eye. what is the most likely diagnosis? Retinal detachment by hands, central retinal arterial occlusion, central retinal vein occlusion, acute angle closer glaucoma. Okay, so I saw maybe some hands for retinal arterial occlusion, retinal vein occlusion, retinal detachment. You almost never have a complete whiteout, or you're not going to see completely black in your vision. You might see something. For acute angle glaucoma, we all know it's painful, not painless. And then central arterial occlusion, vein occlusion are very similar in terms of etiology, but usually with retinal arterial occlusion, you see completely dark, whereas with vein occlusion, you see more like blurry vision. Okay, so this is more likely central retinal arterial occlusion. The etiology of this can be emboli. There's several etiologies. It can be emboli, it can be vasculitis, spasms, sickle cell anemia, and it's going to present with this sudden vision loss. It's also associated with amaurosis fugax, which is what the patient was having in terms of past medical history or associated symptoms. An ultrasound is really not very good for this. Thing is, it's going to be useful to see this what is called like white thrombus, and those are associated with thrombus that have calcifications around them, and you can see this white spot over here in the inside nerve, and that's called the retrobulbar spot sign. There's no information about sensitivity and specificity for this pathology, but probably there's very low sensitivity and then high specificity, meaning if you see it, it's there, right? But if you don't see it, it doesn't mean it's not there. In terms of treatment, there's no good treatment for this, to be honest. We have always been taught that doing an ocular massage can be beneficial. There's no data for that. There's no good data either for TPA administration. So there's really no good treatment. The only thing you gotta make sure to prevent the patient from having this kind of complications again, or CVA in any other area of the brain. Okay. Another thing you can see is this white spot over here that it's kind of outside of the retina. That is not an occlusion. That is called drusen, and it's a false negative. It's kind of a yellow deposit on the retina.
One thing that can help you is a couple of clinical things. I mean, this is good, I agree. But with these, especially if you don't see a lot on this, is one for central retinal artery occlusion. A good amount of them will have AFib. So if they have AFib,
Of course,
that's a clue that this is probably, and suddenly you had that blindness. If you get good at looking in fundi and put them in a dark room, if you get good at it. But if you get good at it, and you put them in a dark room, with central retinal artery occlusion, what you'll see is a pale disc, and you won't see a lot of arteries and stuff. And you'll see a cherry red macula. If they have central retinal vein occlusion, that you can see pretty good. And that you'll see blood and thunder. You'll see these very dilated veins with hemorrhages. And that'll tell you that's a central vein artery occlusion. So that's where sometimes the fundus can help you. Looking at the fundus can help you.
Yep. I think I agree with you. Fundoscopy is way better than ultrasound. Ultrasound is not a good story for this at all. Painful vision loss. So first one is lens dislocation, which is usually going to happen in the setting of trauma. People are going to present with floaters, red eye, diplopia. On ultrasound, you're going to see this biconvex hyperechoic structure, and the lens can be anywhere in the eye. It's very easy to see when there's a complete dislocation. When there's subluxation, you can ask the patient to move the eyes, and that's gonna guide you a little bit better in the diagnosis. You can also diagnose this with slit lamp or CT of the orbits. Important, this is not necessarily an emergency unless the IOP is elevated. In that case, that's totally an emergency, and that usually happens because the lens can block the aqueous flow. Okay. 28-year-old male patient with no significant past medical history presenting to the AD with right eye pain. The patient stated he was drilling a piece of metal when it started. He refused to open his eye. You suspect a foreign body. What's the gold standard for detection of intraocular foreign body? X-rays, CT, ultrasound, physical exam, MRI. MRI is the treatment, Dr. Silver said. Okay, I didn't see any any hands. But essentially, it's going to be CT of the orbits. That's the gold standard. However, ultrasound is pretty good. And with ultrasound, you're going to see this hyperechoic object associated with this reverberation artifact. And that's very suggestive of a foreign body. Of course, history, physical exam is also going to be suggestive of that, especially the history. Older data says that this is like 88% sensitive and 85% specific. Newer data, at least from ACEP, is saying that it can be up to 100% sensitive. But remember, ultrasound is always user dependent. Okay. Always keep orbital rupture in your mind before evaluating these patients, because you shouldn't be really doing an ultrasound on anybody with globe rupture. Okay. Having said that, we're going to discuss globe rupture just because this is an academic setting, right? But it's not going to be my recommendation to do an ultrasound on a patient with globe rupture. Okay. And the reason is because you're going to extricate all the vitreous humor from the eye. Okay. All right. So the theory behind this, some people did studies in terms of whether the pressure from the ultrasound done right with a bunch of gel actually increases the IOP. And apparently it doesn't increase the IOP more than your physical exam. And then in terms of your physical exam, or of your ultrasound, you're gonna see an anterior chamber collapse. You can see a decreased globe size, a loss of the elliptical shape of the eye, and then you're gonna see a bunch of vitreous opacities. Okay, this is an emergency, of course. You're gonna consult ophthalmology for this. My recommendation, if you see a patient with this kind of eye in the setting of trauma, you're likely gonna do a CT. Either way, I wouldn't probably do an ultrasound on this guy. So retrobulbar hematoma it's also going to be painful, usually in the setting of trauma. And you're going to see this hyperechoic structure in the back of the eye that is going to be compressing the globe. So some people call it the guitar pick sign, just because of the shape that the eye takes when there's a retrobulbar hematoma. So the important thing to consider over here is compartment syndrome. Now, compartment syndrome is a clinical diagnosis. You shouldn't use ultrasound to rule in or rule out this. You're just going to go clinically, and we discussed a little bit about this, but you're going to see a proptosis, vision loss, a lot of pain, dilated pupils, and then the intraocular pressure is going to be elevated. If you suspect that, you're going to do a lateral contotomy and contolysis. Ultrasound is 87% sensitive and 88% specific for retrobulbar hematoma. So if you don't see it and you think that the patient has compartment syndrome, just treat it. Okay. Endophthalmitis, we discussed this a little bit earlier, so I'm just gonna say, if you see somebody has an infection, ultrasound can help you to see if the patient also has an infection in the vitreous humor itself, and you're gonna see a bunch of debris in there. And this is important because it changes management. As Aaron was saying, you're gonna do intravitreal antibiotics or systemic antibiotics. But again, this should be clinical. Elevated ICP. So the gold standard is actually invasive. We don't do ICP monitoring from a standpoint. It's actually the neurosurgeon who is going to do it. So ultrasound can help you if you wanna screen for this. Is 90% sensitive and 85% specific. when compared to direct ICP monitoring. And you can do it if you suspect that the ICP is elevated in the setting of the BI or vein masses, maybe IIH or any other pathology. So the way to do it, you're going to measure 3 millimeters down the optic nerve, and then you're going to measure the optic nerve sheath diameter. And it's important to remember is that you're going to measure the optic nerve sheath, not the optic nerve itself. So if you take a look at your PDF, they are actually measuring only the optic nerve. That's not what you're going to measure. You're going to measure from the gray area to the gray area, okay? And that's going to be the correct way to do it. If that line is less than 5 millimeters, then the ICP is less likely to be elevated. If it's 5 to 6, it's an intermediate zone, so you cannot really say it's elevated or not elevated. The patient needs more studies, right? And then if it's more than 6, then that's abnormal and it suggests ICP elevation. All right. This is the first ultrasound I did, the first ocular ultrasound I did during residency. It was a 50-year-old female, past medical history of hypertension, depression, diabetes, who presented complaining of non-painful bilateral blurry vision, bilateral lower extremity weakness, headaches for 2 months. She had a breast mass in the left breast that it was irregular and it was present there for 5 years. She had a biopsy of that mass, but the results were pending. Otherwise, on exam, she had bilateral lower extremity weakness, some ataxia, and decreased visual acuity bilaterally. So anybody knows what we're seeing over here? Yeah. But do you know what it means? Papilledema. Yeah, papilledema. So this patient had leptomeningeal disease secondary to metastasized breast cancer, and she had elevated ICP as well. Okay. So ultrasound is like 82% sensitive and 76% specific for this. Not great, but it's something you can see. Okay. So pros and cons of doing ultrasound. First of all, it's quick, it's easy. There's a lot of pathologies that are going to present very similarly in patients. So it's a little bit difficult to distinguish from your HPI and your physical exam what the patients are having. We don't tend to do fundoscopy either because we don't have it available or because we maybe don't feel too comfortable with it. We also need to dilate the eye in order to do a good fundoscopy. So ultrasound can be a quick way to evaluate the patient. Another thing is that if you see something positive, you can call the ophthalmologist and you can expedite the care for your patient. I do remember I did an ultrasound on a patient who was complaining of, I think it was like, I don't remember his chief complaint, but it was vision loss with, I don't remember what, but essentially I saw a retinal detachment. I called ophthalmology and within 10 minutes he was in the clinic being evaluated by them. So the care was definitely expedited for that patient. So it's something to be aware of. In terms of disadvantages, as any ultrasound stuff, it's operator dependent. If you don't see anything, it doesn't mean that the patient has anything. You gotta use your clinical judgment for this. And regardless if you do an ultrasound or not, sometimes you're gonna end up calling ophthalmology either way, or maybe doing a CAT scan, an MRI. So sometimes it doesn't really change management. However, it can expedite management. Okay. So summary: apply a lot of gel, maintain the patient comfortable, get quality images. Negative ultrasound doesn't rule out any pathologies. Clinical judgment is better than the ultrasound. But positive ultrasound can expedite the management of the patient, and you are gonna have like a legit question for the ophthalmologist as well. Okay. Right. Cool.
It's open, you should not do an ultrasound. There's a foreign body, a laceration, one trauma you can't